Welcome. Today, we're diving deep into the complex world of interstitial lung disease, or ILD. Now, this isn't just one disease. It's a huge family of over 200 different disorders. And because of that, getting the diagnosis exactly right is absolutely critical.
So, to really get a handle on ILD, we have to start with the absolute basics. What part of the lung are we even talking about? A lot of people hear the word interstitium and think it's just the empty space between cells. But that's not it at all. It's actually a complex and vital network of tissue that plays a huge structural role.
So here's our game plan. We'll start by decoding the lungs framework. Then we'll look at how ILDs are classified today. After that, we'll dive into a tale of two very common patterns, cover the typical signs and symptoms, and finally, we'll walk through the path to diagnosis.
Okay, let's jump right in and clear up that big misconception about the interstitium. It's not a void, it's really the architectural foundation holding the entire lung together. Think of the interstitium as the lung scaffolding. It's this continuous web of connective tissue that has a few key parts. You've got the tissue that anchors everything, the tissue that surrounds all the blood vessels, and the tissue that gives structural support to the tiny air sacs where gas exchange happens. It really is the complete structural matrix of the organ.
And here's the crucial point. The main battleground in ILD is what we call the lung parenchyma. That's a fancy term for all the functional, working parts of the lung, the air sacs themselves, and all the important supporting tissues right around them. And that right there is why many experts now prefer a more specific name, diffuse parenchymal lung fibrosis. It just describes the problem so much better. The core issue is fibrosis, which is widespread, irreversible scarring of the lung's functional tissue. This is all driven by some really complex inflammatory signals, with things like TGF-beta playing a starring role.
Okay, so you can probably see how complicated this gets. With hundreds of conditions, we absolutely need a structured way to classify them. So let's take a look at the modern framework doctors use to categorize all these different diseases. The latest guidelines from 2022 basically sort all ILDs into 5 main buckets. For our purposes today, we're really going to zero in on the biggest and most clinically important group, the idiopathic interstitial pneumonias, or IIPs.
Now, within that big group of IIPs, you basically see two major patterns show up again and again on scans and under the microscope. We call them usual interstitial pneumonia, or UIP, and nonspecific interstitial pneumonia, or NSIP. And telling these two apart, it's a huge deal because it directly impacts the patient's prognosis and how you treat them.
First up is the UIP pattern. This is what you typically see in people who have idiopathic pulmonary fibrosis, or IPF. And its radiological signature on a high-res CT scan is something called honeycombing. It looks like clusters of little cysts with thick walls, and it's a dead giveaway for end-stage fibrosis. The lung's architecture is just completely and irreversibly destroyed. What's really wild is that you'll see this permanent scarring right next to areas of active damage and even some bits of relatively normal lung.
Now, contrast that with the second pattern, NSIP. It looks totally different on a scan. It's known for what we call ground glass opacities. And it looks just like it sounds, a hazy, foggy appearance in the lungs. You can still see the blood vessels through it, but it's cloudy. This haze is usually a sign of a more uniform, active inflammation, and importantly, something that might actually be reversible. This table really lays out the differences perfectly, doesn't it? On one hand, you have UIP. It's classic for older men, often has no known cause, and is defined by that irreversible damage you see on a CT scan, like honeycombing. And unfortunately, that means a poorer prognosis. On the other hand, you've got NISIP. It's more common in younger women, often linked to autoimmune diseases or even certain drugs, and presents with that hazy, ground glass look suggesting inflammation. The big difference? It generally has a better, more treatable course. Now, this is fascinating. You might think smoking is a risk factor across the board for lung diseases, right? Well, with ILDs, it's not that simple. It turns out smoking is strongly linked to precisely 4 distinct types of ILD. These include conditions like respiratory bronchiolitis-associated ILD, desquamative interstitial pneumonia, Langerhans cell histiocytosis, and that UIP pattern we just talked about, but specifically when it shows up in someone with rheumatoid arthritis. Okay, so we've talked a lot about the patterns and the pathology deep inside the lungs, but what does this actually look and feel like for a patient in the real world? Let's talk about the clinical signs and symptoms. It really boils down to 2 main things. First, a nagging, dry cough that just won't go away. And second, shortness of breath that gets worse with activity.
That dyspnea on exertion happens because the scarred up lung tissue makes it really hard for oxygen to get into the blood. And you feel that most when your body is demanding more oxygen, like when you're moving around.
And then there's this signature sound. On a physical exam, when a doctor listens to the lungs with a stethoscope, they can hear something called Velcro-like crackles. And it sounds exactly like what you're imagining, like someone slowly pulling apart a strip of Velcro. It's caused by small airways popping open late in the breath, and it's a very specific clue that there's fibrosis in the lungs.
All right, let's put all the pieces together. How do doctors go from those first symptoms, from hearing those crackles, to arriving at a definite diagnosis?
The whole diagnostic journey follows a pretty clear path. It starts with the patient's symptoms, gets a major boost from clinical signs like those Velcro crackles, but the real game changer, the cornerstone of diagnosis, is imaging. The high-resolution CT scan is the absolute key. Seeing the specific pattern on that scan, whether it's UIP, NSIP, or something else, is what ultimately determines the final diagnosis, the treatment plan, and the patient's prognosis. So, if there's one thing to take away from all this, it's that interstitial lung disease isn't a single entity. It's a complex mosaic of more than 200 distinct conditions. This incredible diversity means our diagnostic tools have to be more and more precise. And that leaves us with a really important question for the future. As our understanding of the science gets deeper, how will our diagnostics and treatments evolve to keep up with all this complexity?